So intraoral endodontic examination, palpation. When inflammation is gone through the cortical bone. Percussion. When inflammation on the apical periodontal ligament directly proportionate to the amount of inflammation and does not include pulp health. So determining percussion, um, when you do when you assess inflammation of the periodontal ligament, which is directly proportionate to the amount of inflammation, does not indicate pulp health, because you could be having problems with a high restoration in which you periodontal ligament, thus you have an effect to periodontal you um, when you do percussion, but this does not determine the health of the pulp. Thermal test, cold or hot, the value. Remember that the left way to check the temperature, thermal test is with isolation of the tooth that you're going to check, isolation with a um, rubber dam. So thermal test, cold or hot value when pain is diffuse, helps to localize pain. Electrical test can be done also. Electrical test can be done also. Periodam, mobility, selective anesthesia, and cavity test. All these are intraoral endodontic examinations. What does positive percussion indicate? Pulpitis. It can mean also ortho movement. So you have a periodontal ligament that is sensitive. It can also indicate a lateral periodontal abscess, or it can indicate a high restoration that you have in the mouth. Thus, you are having periodontal ligament inflammation or sensitivity. What type of thermal tests are there? Cold and hot. In cold, you can use carbon dioxide ice sticks, which are at a temperature of -77 Celsius or -108 Fahrenheit. Ethyl chloride is -5 Celsius, and dichloride, fluoride dichloride, and endo ice, which is 30 Celsius, -30 Celsius or -4 Fahrenheit. When you do hot, you can use warm sticks. You can do dry prophy cup that has been warmed. You can do hot water with rubber dam, which is the best way to check. Thermal test. Okay, temperature test can relay the following. There can be no response, it can be mild to moderate, it can be strong, and more than strong. So, no response, it's negative, non-vital. It will be a necrotic tooth. You can have a false negative in immature apex, trauma, or calcification. You can have no response on a tooth, and it can be a false negative if you have an immature apex, trauma, or calcification. Mild to moderate There is slight pain subsiding 1 to 2 seconds. Strong painful response subsides 1 to 2 seconds after, and this will we do reversible pulpitis. 1 to 2 seconds, the pain subsides. Now, if you have a very strong and lingering pain for a few seconds, for several seconds, it can be irreversible pulpitis. So, electrical test does not suggest integrity of the pulp. Electrical test does not suggest integrity of pulp. Suggest presence of vital sensory fibers. So if you have an electrical test and you have a positive electrical test, it does not mean that you have a vital pulp. It means, or integrity of the pulp. It means that there is a presence of vital sensory fibers. Electrical test does not correlate histologically health. So you have electrical test, positive on electrical test, it does not correlate histological health. It is contraindicated in patients with pacemakers. When can we get a false positive reading on electrical tests? When there is contact of the electrode with metal restoration or gum, liquefaction necrosis, anxiety of the patient, or bad isolation. When can we get false positive reading? Anxiety of the patient, bad isolation, liquefaction necrosis. Why liquefaction necrosis? Because there is a liquid in there. Okay? And when there's contact of the electrode with metal, restoration of gum or gum. When can we get a false negative or electrical test? Patient heavily medicated, an alcoholic, bad contact of the electrode with teeth, there's trauma, there's calcification, immature apex, or partial necrosis. All of these can give you a false negative. So a false negative means that it will seem to be negative, but it is not determinant. So it is actually not a test that is giving us any results. It is false, but the information that is false is not reliable or is not true. So periodontal exam, single pocket in absence of periodicis. Single pocket in absence of periodicis, it'll make us suspect of a vertical fracture. When there is a single pocket, then there is an absence of periodicis. Probing and pulp test necessary to distinguish if perio or endo. If the problem started as a perio problem or if it started as an endo problem. Mobility exam, attachment apparatus, periodontal ligament integrity. Inflammation of periodontal ligament. Mobility can be caused also by horizontal root fraction, trauma, bruxism, or ortho movement. Remember, mobility exam, attachment apparatus, periodontal ligament integrity. You may be compromised when you have PDL integrity, when you have mobility. Inflammation of the periodontal ligament. Selective anesthesia. When we cannot locate source of pain with other tests, we infuse anesthesia. This is not a conclusive test though. Cavity test. Cavity test, only done when strong suspicion of pulp necrosis and is corroborated corroborated with X-rays and other tests, but not definitive test is required. But definitive test is required. A radiographic test, X-ray finding not evident until inflammation goes to cortical or bone. Again, radiographic test, X-ray finding not evident until inflammation goes to cortical or bone. We may have medullary bone resorption before showing an X-ray film. I always use two films, one perpendicular to X-ray, one with a 10 to 15 degree angulation. Do not rely only on X-rays for diagnosis. The slob rule, which means same lingual, opposite buccal, means the slob rule that the object closer to the X-ray will move to opposite side that we move the film. Objects further away from the X-ray will move to the same side when we move the film. Slob rule will help with location of additional canals, distinguish superimposed objects, differentiate types of resorptions, determine buccal and lingual position of fractures, locate foreign bodies, locate anatomic landmarks. Now there is a table with radiographically differential diagnosis of periradicular radiolucency. There is a radiographic differential diagnosis of periradicular radiolucencies. So you have a radiographic differential diagnosis in the first lane. The second lane is the periradicular radiolucency and how to distinguish. So you have a vertical root fracture. The periradicular radiolucency will be where you will see apical periodontitis in a vertical root fracture. In a lateral periodontal cyst, you will also see an apical periodontitis, but you have to trace lamina dura and you have to do pulp test. And this is how you're gonna distinguish and how you're gonna realize if what you're seeing on your X-ray on that apical periodontitis is a lateral periodontal cyst or what else it is. So you're gonna trace lamina dura and do pulp tests, because the lateral periodontal cyst, even though it might be on the apical of your tooth, you will see that it's not coming from the endo. It's not an endo problem. So it will be on the outside, it will be lined by a lamina dura, and you will have, if the tooth is not compromised endodontically, and if there's no, and even if it was, if there's no relationship to the finding, it will have a lamina dura and it will have a response of the pulp test. You will have to analyze the pulp test results. Now, if you have a traumatic bone cyst, you have a traumatic bone cyst, it also will look like an apical abscess. It will look like an apical abscess. How are you going to distinguish this? Well, if you have a traumatic bone cyst, apical abscess, you're going to do pulp vitality test. Because besides the health history that you're going to find, if you have a pulp vitality test, you will see that in a traumatic bone cyst, many times or most times the patient is not going to have a history of apical uh, of any problems with endo. So you will have apical abscess pulp vitality test. Pulp vitality test will determine and will help you determine, along with the rest of the health history, will help you determine if this is a process coming from the inside, from an endo. Now, a developmental cyst, it will be the same. A developmental cyst, you will see a perioradicular radiolucency, apical abscess. It will look like an apical abscess. And how to distinguish? Is the pulp vitality test. You'll see an apical abscess, developmental cyst, pulp vitality test. Now, a radiographic. Next one, ameloblastoma. In an ameloblastoma, if you see perioradicular radiolucency, it does look like an apical abscess also, but this will be more common in the 4th and 5th decade. Multilocular aggressive lesion, you will see a more common in the 4th or 5th decade. Multilocular aggressive lesion, okay, ameloblastoma. And you can look for images on how that will give you a better idea how an ameloblastoma will be seen. And this is important because many times it gives you a better image of what is it that you're talking about when you are seeing patients in pathology and when you're seeing patients that have a history of ameloblastoma. You will get a chance to compare them with a patient that has just an apical radiolucency derived of endo, and you will see that in a ameloblastoma, many times it will give you an image that you'll see multilocular image. Ameloblastoma. So let's see. Now you have a perioradicular radiolucency that is the differential will be cementoblastoma. This looks like an osteitis condensate. It is well circumscribed, radiopaque base, radiolucent border. Cementoblastoma. You can in a cementoblastoma, it's a classic appearance of a sclerotic tumor fused with the tooth of the roots and surrounded by a layer of thin radiolucency. So So cementoblastoma can be a radiographic differential diagnosis for osteitis condensans. And this is simply a response on the of the bone periapically to an irritation that is a low degree pulpal irritation in chronic. That is, it will show us an increase of the density of the periapical bone. This is seen a lot in younger patients around the apex of the mandibular teeth with extensive cavities. And yeah. So, how to distinguish? It will be well circumscribed, radiopaque base, radiolucent border. That's what you're going to see in a cementoblastoma. The difference with osteitis condensans will be that there is no the osteitis is not well circumscribed like the cementoblastoma is. And then giant cell granuloma, we will see a big radiolucency with ragged border, faint trabeculae. Giant cell granuloma. Yeah, central giant cell granuloma. You will have big radiolucency with ragged border, faint trabeculae. Okay, so cracked tooth syndrome features pain when biting, pain when releasing the biting, occasional pain when biting, sensitive to thermal changes, sensitive to sweet and acid foods. Mesial distal crack is impossible to see in the X-ray, and the first molars the mandibular first molars have the highest incidence. How to diagnose a cracked tooth? Can use transillumination. You can use a tooth slot or cotton applicator. You can use a stain, air magnification. But remember that the use of a wedge is also, you can also use it, but is the last resource. Okay, use of a wedge, last resource. So, what is the prognosis for a cracked tooth? If there is isolated probing, it's a guarded prognosis. Extension to the floor of pulp, guarded. If the crack is mesial to distal, is poor. What are the clinical findings of a vertical clinical findings of vertical tooth fracture. Starts apically towards the crown. It usually buccal lingual plane. Isolated probing defect. You will have very often an isolated probing defect. J-shaped or teardrop radiolucency. This is very classical. J-shaped or teardrop radiolucency. Okay. Mimic peridisease or failed root canal therapy. Starts apically towards the crown, usually buccal lingual plane. Buccal lingual plane, usually. Isolated probing defect. What is the etiology of vertical root fracture? Over instrumentation when you're enlarging the canal, mechanical stress of obturation, and placement of a post. The treatment of vertical root fracture, if it's a single rooted tooth, extraction. If it's a multi-rooted tooth, it can be extraction or hemisection, in which you use each hemisection and root canal therapy, both hopeless prognosis. Endothelial lesion is a lesion that has communication of pulp and the periodontal ligament, either through the apical foramen, a lateral or accessory canal furcation canal, or dentinal tubules. Types of endothelial lesion. Primary endolesion, primary period lesion, primary period with secondary endolesion, or true combined lesions. Let's read about this. Okay. Okay, so we're gonna take 5 minutes and we're gonna go over this subject. We're gonna go over endothelial lesions.